Excellent, thanks Amy. Morning and welcome to this meeting of the Board of Directors of Lincolnshire Partnership NHS Foundation Trust. My name is Kevin Nokia and I'm the Trust Chair. It's our practice to start our board meetings with a patient or carer or sometimes staff story. And we do this because we strive to put the patient experience at the heart of all the decisions that we take, and we find it really helpful, really grounding to have direct input into board meetings from patients and from carers and from staff, just to make sure that for the rest of the morning, when we're talking about more abstract things, we've got something that anchors us back to reality. So this morning, really pleased that we've got Sally Spencer, who's one of our governors, but specifically a carer governor, and she's joined by Donna Bradford, Head of Carer and Relative Experience. Sorry, Donna, that didn't slip off the tongue quite as well as it should have done. I can't see Sally on screen, unfortunately. Oh, you're both there, both on the same camera. Fantastic. So Sally, over to you. Thank you very much for giving up your time this morning and thank you for joining us. It's a pleasure to have you here.
Good morning, everybody. My name is Sally Spencer. I'm married to Brian and I've got 2 children, Josh, who's 24, and Tom, who's 21. I work full-time for Lincolnshire County Council, supporting children's services, and I'm also a carer governor at LPFT. This is my story that I would like to share with you. We were a happy family despite both of my sons being diagnosed with autism whilst at school. They both did okay at school and we used to go on family holidays, have friends round to our house for social events and do normal family things. When Josh was 10, he started to play football with a team and he loved it. At age 14, he changed teams and they got a new manager. He started to weight train due to the banter within the team and his teammates being bigger and stronger than him. At age 15, one of his teammates pushed him over at a game, resulting in him increasing his weight training to become bigger in stature and believing it would make him taller than his 5'8" height. He also started getting anxiety and panic attacks and being sick every day before school. He got a crush on one of his teachers and he really didn't know also how to manage it. Around the time my mum was diagnosed with Alzheimer's, she lived alone, which meant I was spending a lot of time at her home looking after her. I believe due to this, I didn't realise how much Josh was actually struggling and deteriorating. He went to college aged 16 to do a sports course, but he went from getting himself there to me having to take him every day due to his anxiety. I went to the GP and persuaded them to put a referral into CAMS, which I wrote myself. He was seen for a few weeks, but this quickly stopped as they believed his symptoms were down to his autism. And in 2016, he was discharged as I said he no longer needed the service. Further phone calls to the GP were of no use, as they also put his symptoms down to his autism. At this point, Josh was paranoid about anyone he saw who was bigger than him, and he stopped going out and didn't want anyone coming into the house. Slowly, we were becoming prisoners in our own home. Luckily, one of the GPs did listen to me and started to ring him regularly and put him on propranolol. She also referred him to Step to Change. He did the phone appointment, but they said it was not the service for him and it was his autism and to go back to the GP. They said he needed a referral to a specialist autism service, but there wasn't one. By the time he was 18, he got a CPN, who Josh really liked and got on well with, but she went off long-term sick. We requested a worker who wasn't bigger than Josh, but was told this was not possible and we would have to have who they had, and they also discharged him. He was called by a doctor who recommended he went on to go on antidepressants, but we never received any. I referred Josh myself to social care and he got a social worker who referred us back to the mental health team and also got the doctor to review him again. 13 months later, we had a phone call from a different doctor. She rang him and told him off for not taking his medication, which he'd never ever been prescribed. His review was supposed to be 3 months after the initial phone call, and as you can see, it was a lot longer after that. I had a carers assessment with my mum sometime before when she was diagnosed with Alzheimer's, and I had a yearly review this time by carers first, and my needs had changed as I was not only caring for my mum, but I'd become a carer for Josh too. During the review, I was told about the Carers Education and Support Group at Discovery House, which was every other Thursday in the cafe. This was life-changing for me. I met Donna and all the other carers, and I didn't feel so alone in what was going on for Josh and our family. I learned so much about different services, illnesses, medication, education, and I also met some new friends. In 2020, Josh was referred for a psychology assessment. Just getting into the appointment was a major issue, as during the car ride, Josh kept seeing people bigger than him, which distressed him. Whilst being assessed, he told the psychologist he'd only come because I told him to, and he felt he didn't need any help as he didn't want to change his training routine, which meant he was declined. Actually, I just want to kind of brief on that. Josh was so triggered. He did so well to get into the appointment when he just wanted to answer their questions so he could go. And he was so paranoid they were telling him to stop weight training. That's why he said he didn't want to change things. They said he would. They actually declined him as well. They said they would refer him to the neighbourhood team, but they declined him and told us to go back to the GP. Things continued to deteriorate with Josh and I was feeling out my depth. I was becoming increasingly concerned for his and our family's safety. On a rare occasion, he'd gone to the shops when he thought not many people would be around, but he attacked a man in the street who had a child with him because the man was bigger than him. Luckily, the man was able to prevent him from hurting him, and the police brought him home. Josh said he believed that the man was taunting him with his size and would overpower him. Thankfully, no charges were brought against him. In desperation, I begged for a consultant appointment and got a 2-minute phone call, and he was prescribed quetiapine. I phoned Donna in December 2020 as I was so low at this point, and she came out to see me one evening and we went for a walk. I told her everything that had been going on and she made a crisis referral the next day. Within 48 hours, we had the home treatment team coming in most days, and they referred him back to the CMHT and we got a CPN. Donna referred Josh for a CTR as she felt his deteriorating mental health meant he was at risk of admission. We got a care package put in place with 30 hours of support, but this was too overwhelming for Josh, and the care provider was also only able to provide up to a maximum of 5 hours a week, sometimes less than that or nothing at all, and it fitted around them and not his needs. Staff then felt Josh was dangerous and it was only deemed he could be seen by staff in pairs. So if one of the staff was on sick or on holiday, Josh didn't get a visit from the CMHT. He had a psychologist, the large number of professionals we had involved slowly started to dwindle until again Josh was left with barely any support despite a further 2 CTRs, and the care company withdrew as they were not able to supply appropriate staff. No one was able to sit with Josh while I attended my mum's funeral, even though I gave him a month's notice. And for his safety, that meant we literally had to be out 3 hours and back to make sure he was okay. In November 2021, Josh was seen by a consultant and his meds were changed and increased, but a couple of days later he attacked the Asda delivery man. I rang Donna, who told me to ask for a mental health assessment and gave me the details. She also liaised with the AMP and the Section 12 doctors. I felt mine and my husband and son's safety were at risk, and we were all very frightened by Josh. He'd been regularly threatening Brian and Tom, and we were no longer to watch TV at any point due to people on TV being bigger than him, or that something they said might trigger him. He would physically push Tom around, who at this point locked himself every night in his bedroom out of fear. He'd snatched my phone off me when I tried to call the police. With Donna's help, he was sectioned and taken to 3 different wards before being placed at Eagle House, where he remains now. Every day is still a battle. Staff continue to see his autism and not his mental health. Josh was a friendly, although a quiet boy, but he enjoyed his childhood, family holidays and interacted with others in his football team. He now stays in his room to isolated himself because he can't cope with the people around him, and he only goes out twice a week to visit us at home. Even that's distressing for him because of the people that he sees on the way to our house. He rings me at most evenings, which I often dread because the conversation is always ending with he wishes he was dead. Although a recent change in his antidepressant has certainly lifted his mood, however, he's still paranoid about bigger people than him, and that although he knows they can't overpower him, they've got the potential to. I am a realist and I know that he may never get back to the way he was, but I believe he can be better than he is now. I had a breakdown last year when Josh was on the last ward. I think the stress of the previous years looking after him and fighting for him and all the fear had taken its toll on me. The trauma continues even though he now does not live with us. He's my son and I only want the best for him, and I will continue to support him to get the help he needs, and that will never change. I wish there'd been consistency in services with regular staff and regular medication reviews. The most consistent person throughout all this has been Donna, and I honestly don't know how I would have got through this without her continued support. Due to my experience, I became a staff governor. I'm so grateful for the services we did receive, and nearly all the staff we encountered were absolutely great, but the system let us down. It wasn't the staff. The majority of staff were absolutely fantastic, but it was the system. I felt we really need to address this. I think the Triangle of Care initiative is so important for the Trust to include carers as part of the care team as experts in their care. I'm heavily involved with this with Donna and other carers to make a difference. I'm passionate about all carers receiving the support that I have through this initiative. Thank you for listening, and I'm happy to take any questions you may have.
Thank you very much, Sally, and thank you for being so honest and forthright and and clear. And I'm absolutely sure that can't have been an easy story to tell. And I'm glad to hear that your son is a bit brighter in mood now, and that there are signs of him getting a little bit better. And you've said a number of things that I would have said, and I would have reached similar conclusions. So your point about consistency is, I think, really well made, and one that as a trust we're really well aware of, but we also know that there is a lot more that we need to do. And I think that the feeling that you describe of being, as it were, at the mercy of a system that doesn't understand what you need and what your son needs and what you want, I think is a really powerful one, and one that certainly resonates with us. But I'm not going to hog the opportunity to ask you questions, so I'm going to ask if any board colleagues have got questions they'd like to ask or comments that they'd like to make. But Sally, thank you again. Girish.
Yeah, thank you, Donna. I'm Dr. Kunigiri. I'm the medical director in LPFT. It is really touching, what you have been saying, and this only emphasizes that what we need or what we do needs to significantly improve, and it should be a continuous journey. I think my plea for you and your team, particularly from the care's point of view, is it will be helpful for you to be involved in sharing this story with our clinicians as a group, because that is really powerful for us to listen as a group and then reflect. So I will be in touch with Donna, with your team in terms of having some arrangements so that we have regular input from patients and carers in terms of our teaching and training. Thank you.
Thanks, Girish. Sarah.
Thank you. Sarah Connery, Chief Executive at the Trust, and thank you, Sally, for being so brave and so generous with your time to tell your story today, and that of Josh and your wider family. And thank you again for Donna, who, just as an aside, I think we could do a whole board story with just Donna, talking about how Donna, she's probably blushing now, how she papers over cracks and picks up pieces where people fall between gaps in services. But it shouldn't have to be that way, and I'm very grateful for her for doing it. But I think there's something about how we use that learning to make sure that we've actually got the system working as it should do, rather than it being having to step in to make things work and connect the dots where it's not so easy for people who are using services to make those connections. But my comment is just, we've actually got the autism strategy, the system autism strategy later on in the board, where support for autistic people and their families, you know, we're finally getting some investment in terms of not just post-diagnosis support, but just if people need that support, then it is available for them. So I know we were doing the recruitment this week, so I'm feeling that there's hope at the sort of in terms of moving us forward, making sure we've got that no wrong door, making sure that people can access that support in a more easy way. And our key worker service as well, at the minute it's just for children and young people, but we are extending that up to the age of 25. So I think it's because of stories like yours and Josh's, Sally, that, you know, we've seen the need for, we've seen the gaps, and we're doing as best as we can to fill them in. But I know we had a conversation earlier this morning, didn't we, about the Oliver McGowan training as well, where, you know, so important to make sure that we're making reasonable adjustments for people. So, you know, you offered very kindly again if you could get involved in sharing your story and Josh's story to help with that. So I'll be in touch, I suppose is what I'm saying. But thank you again.
Thanks, Sarah. If you'll forgive me, Sally, I'll make a couple of further points before I bring in a couple more board colleagues. I think that for the 2 years I've been chair of LPFT, I've been frustrated by the fact that we have gaps between services. We shouldn't have gaps between services, and those gaps that have, you know, so terribly affected you and Josh and your family shouldn't be papered over by Donna, however brilliant Donna is. They shouldn't be there, and we know that they're there. And you know, Sarah alluded to the notion of no wrong door. A bit later this morning, we're talking about the refreshed trust strategy, and one of the objectives of that strategy is to try to eliminate those gaps between services and to do much better at stopping people falling between those gaps. And if it wasn't for stories like yours, Sally, and, you know, kind of the honesty of you and others telling us about how our services feel when you experience them, we wouldn't be having that conversation later this morning, and we wouldn't be having a trust strategy that hopefully makes your experience less likely to happen in the future. That doesn't change it for you, and I'm dreadfully sorry that it doesn't change it for you, but there is real value in, you know, your story and your experience, and we will do our best to work with it. On that point, I'm going to hand over to Chris Wright.
Thank you, Kevin, and thank you, Sally. I found your story very distressing, and I admire your resilience and your family's resilience. And I'm just going to reiterate some of the things Kevin has just said, actually, because I guess I've been involved now for just over a year, and I'm frustrated that there are common themes that we consistently hear about the failure of the system to connect and join up and own individual case studies or individual stories, and it just feels like there's a systemic failing that we need to get right. It's an obvious thing to say, but there's no point just keep on saying it. We've got to do it, and I'm frustrated that people like you, Sally, have to spend so much energy trying to get people to listen to you know, the story, and we've just got to be better, and we've got to find a solution to connecting the experience of individual situations so that we can, you know, join the dots. And it's just, I just find it, I actually find it quite well, shocking that we're in this situation. And so I think you coming in saying it, Sally, is really powerful, and we have to do something about it, and we have to move quickly. And Kevin, you're right, the new strategy sets out a journey that we're about to embark on, but we need to move at pace, and otherwise, you know, we can't continue continuously listen to these stories and these common themes. Otherwise, we'll just be failing in our responsibilities. Thanks, Sally.
Can I just say something?
Of course you
One
can,
of the things
Sally.
Josh will say to me is, Mum, there's no hope for me. This is my life, and I hope my life's short, because you know this is kind of grueling every day. He said, but if there was a way to make me feel better, they would have found it by now. And I think that a lot of that is because he's had that many different services, but he's not had that consistency, and it's kind of fell a bit by the wayside. Like, for example, Transforming Care, when he was in hospital, he finally got a psychologist, but he left the service. And kind of his CPN that he's got now, we requested psychology again for Josh. You know, when he was suicidal all the time. I mean, I was at my friend's funeral and I was getting phone calls about him being suicidal. It's unfortunately, it's grim. Do you know what I mean? Kind of what having to deal with. But the answer was, Josh said to me, I've had my psychology, and so that's it. And actually, what I will say, there is a lovely lady called Alyssa in the rehab team who supported Josh from before he came out of hospital, and still chairs a monthly meeting to make sure that, you know, kind of my views are met and Josh's as well. And kind of I explained this to her, and you know, because of how Josh is feeling, and she actually got in touch with Tom, and it turned out that some of the work that should have been done after Tom left wasn't done. There was supposed to be training put in place at Eagle House for the staff, but that didn't happen. And it wasn't so much LPFT. When they did try, they didn't even give a suitable room for it to be done. It was going to be in front of all service users about Josh. So it's things like that, you know, and it just gives Josh a message. I'm not, do you know what I mean? I'm not going to get any better, because he's black and white thinking. And it's just so, even though Josh doesn't live with me now, I am still having to fly that flag every day for him. And also with Donna, that when Donna came for that walk with me that day, to be honest, it had been like, you know, no wrong door. I'm part of that initiative, and again, it's really important to me. But every door was shut, and basically I tried to manage Josh all the time, and they got to a point I couldn't manage him. It was when they declined the psychology originally and put him to the neighbourhood teams. When I rang them, they said, oh no, it's your GP, but the GP hasn't got funding. And I begged for that appointment with someone, but Donna came to see me, and I've resigned to myself to the fact that it was just me and him, and what was going to be was going to be. And if Donna had to come and got that the crisis team in the next day, I don't think I'd be telling you my story, because I don't honestly think we'd be here. And it's quite grim to say, and I'm sorry about that, but I really think that's so important that that you hear this. I mean, Donna, I can't tell you how she kept me going, and you need the value of it is so important, because there is not just me going through this. There is so many other people, and like Donna arranged appointments to keep Josh out of hospital, but there was a lot of really good things that came out of it, but they didn't. The actions didn't materialise into actuals. And one of the things they promised us was like a specialist psychologist, you know, autism trained to help with Josh. Also, Josh was diagnosed when he was very young, and kind of the diagnosis was very different then. And because of obviously Josh has really changed, I asked for kind of them to re-look at that, because we need to see what he is now, with obviously with all his mental health issues as well. I mean, that crisis team was the first person who came in to say, Josh, I can see you're depressed. This is the major thing, not your autism. I just wanted to say that, because it's things that really, you know, hit hard with me.
Thank you, Sally. I've got a couple more things I want to say before we bring this to a conclusion, but I've got a couple of colleagues, if you don't mind, who've got comments before we do. So I'm going to go to Di first.
Thanks, Kevin. Thanks, Sally. I'm Di Bailey. I'm one of the non-execs, and I chair the quality committee for LPFT. I don't want to reiterate what everybody said about, you know, how difficult this is to hear for us, but also how difficult this has been for you and your family. And I think it is really important that we listen and we try and heed some of the things that you've been talking about. So I'd just like to go back to where you ended, really, which was about Josh himself, and it's hard again to hear where he's at in terms of his thoughts for the future. It made me wonder where advocacy sits here for people who are in our services, and whether Josh has had any experience of that, or whether that's been discussed at any stage, and if that is something that, if you know, going forward, is that something that you know, we might think about? I don't know. I'd be interested in your thoughts about that as a carer and as Josh's mum.
I suppose I am his advocate.
Right.
I always have been. I'm the one who fights for him, and that's why he's also got that reliance on me as well. I'm the one who speaks to the professionals. What I will say with the professionals that are involved, that they've always, I've had a really positive thing with the triangle of care. They've always taken my views. I mean, when things were really bad at home, the 2 CPNs that came were checking in on our safety as much as Josh to make sure we were okay. So I suppose I've always been that advocate. I do worry for, if something happens to me, what's going to happen to Josh, because these problems of him have not gone away. I've still got to keep fighting till kind of I get him kind of some continued service that is going to support him. I mean, like, he's never seen the same doctor twice. I don't think anyone really knows Josh. One thing I wanted to give to you today was a couple of pictures of Josh, but just due to timing and other thing, I couldn't do that. But if it's okay with the board, because I need to bring Josh as a human. I'm telling his story, but actually this is the story of my son who's still struggling. So, you know, just so you can actually see this is him. Yeah,
of course, that would be fantastic, Sally.
Okay,
thank you, Di.
Thanks, Kevin. Thanks, Sally.
And Tim.
Thanks, Tim. I'm going to be really brief because colleagues have really said what I want to say. The one thing I did just want to sort of reinforce is, you know, Kevin has referred to the review of our strategy and where we recognise there are issues, and it's all about solutions, as Chris said. You know, we've got to do things differently. But I think what is so important is Sally, with your lived experience, you know, the solutions are really need to be shaped by people like yourself, you know, with that lived experience. So please carry on inputting. Thank you.
Thanks, Tim. A couple of final comments from me, Sally, if you don't mind. The first is that stories like you, first of all, I'm really humbled by both by you and by your story. Humbled because I think we need to hear as a board where we're not doing as well as we aspire to and as we want to. And although I found hearing your story emotionally quite difficult, and I'm not suggesting that it's anything like as difficult as it must have been for you to tell it, but it's difficult to hear and it's humbling. And if I'm honest, it's really healthy for me to be reminded that we don't always get it right. Now, there are some things that we're doing that hopefully, as I've said, will make your experience less common in the future. So the review of the strategy, the fact that we're investing in a key worker service that will provide, you know, kind of more holistic care around patients and families. I think that for the future, that will make a real difference. And if we can give, you know, realise the whole no wrong door approach, I think that will make a difference. But we need to keep hearing from people like you, Sally. We need to understand when we're not getting it right, and we need to be able to properly emotionally understand, you know, how we convert our strategic ideas and plans into things that really make a difference for patients and families. So please keep telling your story to us. Thank you. Thank you, Sally. As I say, it's a privilege to hear from you, and it's a humbling experience this morning. And And thank you, Donna. You keep dipping in and out of the picture for me, but thank you, Donna. You know, it's really clear
She's
to
the
me.
best.
It's really clear to me that Sally wouldn't be here telling her story in the way that she is if it weren't for you. So thank you, Donna. Thank you very much, Sally.
She is part of my story, Donna is.
Yeah, that's really clear. That's really clear. Thank you both.
You're welcome. Thank you.
Thank you.
Okay. It almost feels a discourtesy to Sally now to move on from that to the formal agenda, but unfortunately it's something that we have to do. Apologies for absence. We've got apologies from Sharon Robson, I think, who's on leave, and Sharon Harvey, and Mark, you're here representing Sharon, so thank you for joining us. Don't think we've got any other apologies for absence. If I've missed any, then they'll be in the minutes. Declarations of interest. I think it's proper to reflect the fact, Di, that you've got an interest in item 6.2 on the agenda. Look, I don't intend to ask you to absent yourself for discussion on that item, because although your arguments are bound to be on anything are persuasive, I'm not sure that you're in a position materially to affect the board's decision on that. So unless you find it too embarrassing and want to go and make a cup of tea while that item's on, I won't ask you to leave unless colleagues feel strongly to the contrary.
Thanks, Kevin. I might take you up on the cup of tea issue. We'll see how we go.
Yeah, of course. If there are any other declarations of interest that aren't otherwise on the register, then please shout. If there aren't any, we'll move on to the minutes of the last meeting, which was as long ago as May. Are colleagues content with the accuracy of those meetings? If not, then please shout, or if there are any matters arising, please let me know. If not, are colleagues happy for me to sign those as an accurate record? Fab, thank you very much. Schedule of actions, item 1.4. There's only one outstanding, which is self-explanatory, and we'll go to board development. Has anybody got any comments or questions on the outstanding action, or indeed any of the completed actions? If not, then we will move on. I've only got a couple of remarks before I hand over to the Chief Executive. The first is I mentioned that Sharon Robson, currently Deputy Chair and Senior Independent Non-Exec, is away today. This would have been her last board meeting before she moves on to take a non-executive position at the Integrated Care Board. I'm sure colleagues will want to join me formally in recording our appreciation of Sharon's contribution to the board and to LPFT. I will miss her, and I know the organisation will, and I know board colleagues will. So we wish Sharon all the best, and I think record for the record that the ICB's gain is our loss. Second thing I want to make is that we got two important, at least two important conversations during the course of this morning on what's a fairly busy agenda. A conversation about hopefully signing off the trust strategy, and as we've alluded to, as Sally's story gave me the opportunity to allude to, this is a really important landmark, as it were, and having the opportunity to sign that strategy off today, I think, is really important, and it's a strategy that I'm particularly pleased with, and I know colleagues are too. I think it represents a really fantastic piece of work, and we need to do that justice when we come to it in a few moments. The second thing I just want to highlight around this morning is we've got, under the people part of the agenda, I think some really important conversations to have, particularly around ED&I, but more generally around aspects of our people approach. So we need to approach that, I think, in the right manner, but they are important discussions. The other thing I'd say, and I probably should have said this right at the top of the meeting, and apologies for not doing so, we have got a busy agenda both this morning and in those items that we need to discuss in private. So I would ask that colleagues that are presenting papers do so on the basis that they've been read, and do so with a bit of economy, and where introductory remarks are made, that they aim to provide important context to the paper and to draw out any really salient points that board colleagues need to focus on, just so that we can go about our business today with an appropriate degree of focus. I'll put it like that. So thank you for that. Happy to take any questions on anything that I've said, but otherwise, if not, I'll hand over to the Chief Executive, Sarah.
Right, thank you very much, Kevin. So, hello, morning everybody. Sarah Connery, Chief Executive here at the Trust. As Kevin said, it's a really important board for us today, and not that any of them aren't important, but you'll see from the report it's been a very busy couple of months, and there's been quite a lot of reflection with NHS at 75 in terms of a really important birthday, in terms of the publication of the Hewitt Review. So I think in terms of the timing of our strategy, just making sure that everything that we've got in terms of our ambition going forward align with what's in those really important national documents. And I think it was really important for us to have Sally's story as well, because that's absolutely what we need to keep in mind as we take forward our refreshed trust strategy. Something that I wasn't able to put in my report, and I just want to flag to everybody today, is you may have seen in the media, yesterday, around the Right Care, Right Person National Agreement. It's been much trailed, and we've discussed it briefly before in committees and boards. And this is a new national framework that's being released in terms of how we respond to people as a system, particularly between the police force and mental health services when people are at their most vulnerable, to make sure that people are receiving care and service from the right trained person. Our relationships with our local police force are excellent. As you know, we have a member of the force who's a governor on our Council of Governors. And so I think we're in a really strong position to take this framework forward. I say we received it late last night, so not enough time to be able to put it forward, but I'll keep you appraised and include it in our next board update. In terms of a few things to flag, the junior doctor and consultant strike, so much planning that went into those, and more dates have in fact been released for August as well in terms of further industrial action. But so much planning went into it to try and minimise impact on patient care as much as possible. And I just want to say a massive thank you to Girish and Amy and everybody else in the Trust who worked so hard to minimise the impact. Well, there's always lessons to learn, but we'll continue to make sure that we include that learning in future incidents of industrial action. I have already mentioned previously in terms of the Lincolnshire autism strategy, I wanted to bring it here. It's not LPFT strategy as such, but we've been really integral in pushing it forward and making sure that we've used members of the autistic community to actually write not only the strategy but the accompanying plan as well. And there's some great pieces of investment going forward around a virtual support hub, which we haven't had in Lincolnshire previously. So I won't go into any more detail, but really happy to answer any questions on that. A real proud moment for us all was when we opened our new wards at the Peter Hodgkinson Centre, followed by a visit in terms of the formal opening by the National Mental Health Director at NHS England, Claire Murdoch, who stayed for most of the day after the plaque showing and talked to our experts by experience and some of our services service leads as well. So she was absolutely blown away and wrote a really touching letter of thanks to us for that. So thank you for everybody who was involved and to Claire for her time. Really excited to get the Planning Commission finally agreed for Northern Lee as well. And finally, I just want to say, in the interest of time, I'll keep brief, but we had a really positive session with our Health Scrutiny Committee about the permanent closure of Ashley House in terms of moving forward with our community rehabilitation services across the county, and also in terms of the next steps around our extended pilot for the Manthorpe closure. So really welcome people getting engaged in the pilot for that and sharing feedback on how the services are and how we want to make sure we're keeping transforming services going forward. So I'll stop there, Kevin, and I'm really happy to take comments and questions. I just want to finish by saying, now that we are refreshing our trust strategy going forward, it's an opportunity to look at my Chief Executive's report and very much want to sort of structure it around the strategic pillars. I think sometimes it can feel a little bit like I'm presenting parish notices, so welcome any feedback from members of the board in terms of if they feel like there's something that I'm missing from the report. So I'm happy to receive that feedback. And I'll stop there. Thank you.
Thank you, Sarah. I've got Tim.
Thanks, Kevin. Just a really quick one, and thank you as ever, Sarah, a lot actually in that. I just wanted to pick up on one line in the commentary about the Hewitt report and a review of the capital regime. And really, I just wondered if you could just give a quick couple of sort of comments. What's the drive behind that? Part of what's behind my question is a theme in terms of the number of visits that I've had where things like accommodation have been a sort of issue where there may be capital implications, and I'm sure there are other solutions around. I just wanted to understand it a speck more.
Yeah, so I think there's a growing concern that the current capital financial regime in the NHS doesn't actually work for us in terms of the capital limits that get set on systems. And as a foundation trust, I know something that we're going to pick up in part 2, we have a healthy cash balance, and how do we access that and provide capital solutions where they're required? Because there is a general feeling, and this is obviously what's been fed back to Patricia Hewitt as well, that some of our transformation in services and in systems relies on capital investment. But accessing that capital is not straightforward, takes time. The ability to be able to spend the money that we have isn't always there. So I think it needs looking at. Does that help? Sarah. Does that help answer the question? So I think there's just general frustrations around it.
Yeah, it does. Thank you, Sarah.
Thanks, Tim. Di.
Thanks, Sarah. Really welcome the Lincolnshire All Age Autism Strategy. And I note that in there, the Oliver McGowan training was mentioned and flagged, which I certainly found really useful. And I just think on the back of the board story this morning with Sally, I think there's probably something that we could do to build on that, because I think one of those areas where we do have challenges is around providing those services to people whose needs span both mental health and autism service. So I just wanted to flag that, really.
Agreed, absolutely, yeah.
Thanks, Di. Chris.
Thanks, Kevin. Sarah, thank you for your report. In terms of comments about what a future CEO report might look like. I think, in a way, if you link this back to the Sally's story, a lot of your time is spent on reporting, engaging on the system, on process, on having to digest huge amount of information, and this board receives huge amount of information, but there's a gap between the information we receive and the actuality on the ground, as evidenced by Sally's story. And so what I'm interested in, and Di just referred to the autism strategy, it's great at producing these things, but we really got to translate the ambition into practice. And that's all about culture. It's all about the way we behave, what it is we do, how we demonstrate our values on the ground. And so I'm not sure how we do this, and it's or how you report on it, but what I'd be really interested in seeing in your report is some kind of representation of what we're doing around the culture and the organisation, how we're ensuring that our colleagues are behaving in the way that we expect people to behave according to the values of the organisation. Because if we were absolutely delivering on our values consistently across the organisation, from every in every role, in every engagement with the people we support, we wouldn't be hearing stories like Sally's. And that's a huge challenge, because there are 2,500 people, but we really need to hold ourselves to account against the values. So I'm not sure that's particularly focused, as Kevin was asking for, but it is it's an expression of frustration that we're really good at reporting on what activity and what's going on and process, but there's a gap between all of that and the reality on the ground, and we've got to try and find a way of closing that gap, or giving us the insights that we need so that we can enable and encourage the kind of behaviour we need to see consistently across our services. I hope you can pull something out of that.
That's really helpful, thank you. I think it's, and we'll come on to it really, won't we, but taking the trust strategy and then making sure that the information that the board receives is showing how we're doing against that trust strategy, and that will be a challenge, but it's one that we have to embrace, or it just becomes another paper document. So thank you for that, Chris.
Thanks, Sarah. And I know that you and I have talked offline, as it were, about how we might reshape your CEO's report, and I think that Chris is right. Something that gives a perspective and as it were a non-systematic one about how our services feel to the people that experience them, without trying to kind of boil that down to some numbers, something that's impressionistic and something that says, from the chief executive, this is what I've done this month or this quarter to reach a view on this, and this is therefore what I think. I think I would find that really valuable, and it starts to bridge that gap, doesn't it, between I use the word advisedly, kind of bureaucratic reporting and something that you can feel about. Does that make sense?
Absolutely.
I think that's the gap
helpful.
we need. That's the gap we need filling, I think.
Yeah.
I've got one more colleague with a question, Ian.
Yeah, thanks, and thanks for the report, Sarah. I thought it was very helpful, very useful. Mine's just in relation to the National Workforce Plan, really, and I know that came out to massive fanfare, but I just wondered, from your own perspective, how much optimism that should give us, given that the staffing issue is one of our major challenges.
Yeah, thank you. I mean, it's again, we've been talking about it a while, so I'm not quite sure which version that we're on in terms of the one that was finally published. But I think it's welcome. I think there's a lot in there around understanding the scale of the challenge that we all face in services, and the role of proper, because we've never had a workforce plan like this before to this amount of detail. The funding that's associated with it, very welcome. And the thing that I'm also interested in, which again I've never seen in any sort of national strategy before, is around a workforce plan around sort of dual roles and more generic roles in terms of patient experience, where and not only that, but just for staff development as well, in terms of having a broad skill set, so that in terms of patient experience, there are less people who you have to see, but you can get the same level of care. So that's something that I think something for us to consider in our own people workforce going forward, in terms of mental and physical health roles combined. The bit I am concerned about is the retention element. So, you know, nationally, we sometimes don't struggle actually to get people onto nurse training courses, for example. It's the retention element that I'm concerned about. There are some big numbers in there, and how we actually make health and care services an attractive proposition to people in the context of industrial action, cost of living crisis, isn't necessarily sort of answered in that workforce plan, but you know, a great foundation for us to build on. And again, really important that we've got that today when we're looking at our trust strategy. Thank you.
Thanks, Ian. Thank you very much, Sarah. Let's move on, shall we? Thank you for that, Sarah, and thank you too, I should say, for your commitment to revisit the format and approach that you take in those reports. Welcome that very much. Let's move on then to item 2.2 and the trust strategy. Chris, I hope you're not put off by the fact that this item's been bigged up a bit over the last hour, so hopefully you don't feel overawed by that.
No, morning. Thanks, Kevin. Yeah, Chris Higgins, Director of Operations at the Trust. Not at all. I'm really pleased to be able to present the draft trust strategy today for us, hopefully to approve, and then we can press on, as you'll see in the paper there, with a whole raft of work to make sure that this is accessible to all the audiences that will be interested in it. Just a couple of bits, just to say, true to what we set out at the beginning of the process, we committed to co-producing the strategy as much as possible, but whilst recognising, acknowledging that the development of trust strategy is the business of the board, hence it's here for us to approve today. But you'll see that there's quite a lot of engagement and activity that's taken place with a whole raft of stakeholders throughout the last few months since we started the process back in November, and hopefully members will see the words and see the iteration over time as we've really taken on board that feedback from different audiences to try to make sure this is meaningful and representative of all our stakeholders going forward. A couple of bits just to say is the trust vision. We decided quite early on in this process, after much consideration, that the trust vision to support people to live well in their communities still stands. It's relevant for us as an organisation, it's relevant in the system, and it's relevant in terms of the national direction of travel for healthcare and particularly mental health, learning disability and autism services. Equally, we talked about our trust values a lot in the process and made a commitment that for now, whilst we're up to this point in time, the values still stand. They're well embedded in the organisation. People recognise them, and really it's a key attraction and retention piece for us as an organisation. But linking back to the conversations we've just had, this is a real opportunity to now look at those and refresh them in light of the new strategy and think about where we want to go forward and what that means for us as an organisation and our staff and other stakeholders. So as we committed, once we've got this agreed, we can then take it forward as a piece of work through our people committee and obviously co-producing that with staff. So just a couple of bits to say is there's a suite of documents that will be produced on the back of this that the board will be aware of: an integrated performance report, board assurance framework that's in development, governance and accountability frameworks, and an integrated delivery plan. And the process of developing our annual planning cycle is already underway, and where traditionally we'd be looking at a year's plan as per the national direction, we're now looking further afield in line with the framework and time frame of the strategy, so looking to that kind of 2, 3, 5 year period. So I won't go on much longer. You've got the paper there. You can see the approach that we're suggesting in terms of media and formatting so that we can make it accessible. The strategy being in its final content's been circulated prior to the meeting, so board members had a chance to have a look at it. We've received some comments on that hopefully you've all been cited on, some minor grammatical bits, but then some other key bits around that. I suggest I pause there, just take questions, but then I think we just need to make sure that we're all comfortable with the content and any final amendments and changes so that we can capture them today and then hopefully get the content approved.
Thanks very much, Chris. It was my suggestion that colleagues feed in kind of drafting changes in advance of this morning. So I think we've had a version with those track changes included, because that seemed to me to be a rather better use of time than trying to redraft it in committee, which is never a particularly enjoyable process. Questions or comments from colleagues, please? I don't see any, Chris. So you've got the action required is simply to approve it. Chris, sorry, you've jumped in quickly with a comment. Go on.
I just think it's important to acknowledge Chris and all the work that he's personally done in pulling this together. I think it's a really impressive piece of work, and the level of engagement with all the stakeholders is something to commend. The point that we're setting ourselves some high ambition in this strategy, and we need to hold ourselves to account against that high ambition. And so yeah, I'm a big supporter of what we're trying to do, but we need to ensure that we do it. And if we don't do it, we have to account for ourselves.
Yeah, thanks very much, Chris. I mean, you preempted what I was going to say. I think this is a fantastic piece of work, and Chris, you and others have worked extremely hard on this in a way that has been almost, I mean, I won't go as far as saying it's a model for how this sort of thing should be done, but it's as close to a model as anyone's ever realistically going to get, in terms of inclusivity and the approach. It's been absolutely absolutely great, and yeah, of course, Chris, has been a team effort, but even teams need to be led sometimes. So Tim.
Yeah, thanks, Jen, and just to fully support the comments to Chris and the team about doing this. And I'm not going to go on for long, because the question today was around the content, which I fully support, and all the refinements. But obviously, your mind races ahead to what next, and just a very couple of quick sort of comments. Sorry, I should have said at the beginning. Tim Harry, non-exec director. Something around, and I know our content teams will be on this, but something around user stories, the visualization, pictures of people, because it's all about people at the end of the day, and if we're going to have vox pops, and maybe how NEDs and governors can help support the communication and engagement around the strategy. I'd be really, really happy to do as much as I can around that. Thank you.
Thanks, Tim. So I think, Chris, I don't think there's any question about whether or not the board, approves the strategy. We've all been involved in this, to a significant degree. It's been through, several board development sessions, and it's just worth noting this is not a strategy that's just been dropped on the board today that we've never seen before. Just as you and colleagues have been really busy, as it were, behind the scenes, this is something that the board is engaged with, really fully. So I think, unless somebody shouts in my ear, the strategy is approved by the board. I think that we will want to come back quite quickly as a board to think about how do we stay on top of implementing this in two ways, you know, because it's perfectly conscious this is going to be supported by you know, detailed delivery plans that are owned by you know, the relevant bits of the business. But going back, as Chris Wright invited us to you know, Sally's story this morning, there's something about, you know, making sure that not only in, you know, kind of dry reporting terms as the strategy, you know, change the way that we want the trust to operate, but that it feels different to the people that experience our services. It was one of the reasons why the final page in this document, which talks about how it will feel to me, is really important. We need to think about how, as a board, we satisfy ourselves that those statements become true. Now, I'm not seeking an answer to that today, but I think it's something that we need to come back to, you know, either in board or through board development, so that we can be confident that those, you know, kind of softer experiential elements are biting, as it were. Does that make sense? Great stuff.
Absolutely.
Thank you very much,
Absolutely.
Chris. Let's move on then to item 3.1, highlights from Quality Committee meeting. Di.
Thanks, Kevin. I'll heed your message earlier to keep it brief, but just a couple of things to add in relation to the highlights and exceptions. So in terms of the Adult Inpatient Quality Improvement Transformation Programme, which is reporting into Quality Committee, since the committee was held, there's been a rapid review into the use of data in inpatient settings. So we've clocked that, and we're going to make sure that in future the recommendations from that rapid review comes through Quality Committee in terms of the way that that programme reports. So so we'll pick that up through that way. And I just really wanted to highlight the conversation that we had in relation to the physical healthcare deep dive, because I think this does chime with Sally's story earlier. So one of the things that we talked about in that deep dive was the fact that we've got different recording systems between ourselves and primary care colleagues, and both ourselves and in primary care is where the physical health checks happen, for example. So one of the actions to come out of the Quality Committee was ways in which we can deal with that immediately to resolve some of those recording and reporting issues, but also this is more of a strategic issue which is feeding into the system level Quality Committee in terms of how then the digital programme at system level can enable some of this better communication to facilitate more joined up services, which, as Sally pointed out to us this morning, is where we need to be. So those were the only two things I wanted to elaborate on. Thank you.
Thanks, Di. Any questions or comments for Di? No, thank you very much. Thanks, Di. We'll move on then to the annual safeguarding declaration. Mark, I assume you're talking to this.
Yes,
Thanks.
thank you, Joe. Mark Holsall, Deputy Director of Nursing and Quality, here on behalf of Sharon Harvey, Director of Nursing and Quality. The annual safeguarding declaration has been presented to board. It's I'll take it as read. It's a very brief declaration. It's supporting the trust to meet its statutory or one of its statutory duties in relation to safeguarding. Following last board of directors meeting, statements been shared with board members for review and comment. The paper here today is asking for board approval of the annual safeguarding declaration to publish onto the trust website as recommended by the Quality Committee. Thank you.
Thanks very much, Mark. So, question, are colleagues content to approve the safeguarding declaration as attached to the paper? Excellent, thank you very much. Thank you, Mark. Now we've got, about to move on to the people element of the agenda. I'm going to suggest we take a 5-minute comfort break before we do, I'm also going to suggest, or a short comfort break at least, I'm going to suggest that we might want to take items 4.1, 4.2 and 4.3 together, certainly in terms of introducing them, otherwise it might get a bit bitty. Tim, if you're content hearing from you with the highlight and exceptions report from the People Committee and then going into Amy's substantive items, because they're so interconnected, I think we might take them together if that's okay with you. So with that suggestion then, it's 5:10. Can we reconvene at 5:15? Thanks very much. Okay, welcome back everybody. Let's move on then to section 4 in the agenda. Tim and Amy, having said we ought to take at least the first 3 items together, I didn't think through how we might best introduce those. Do you want to say a few words, Tim, and then maybe hand over to Amy, and then we can have a discussion around points from your highlight and exception report and the RES and DES annual report and action plan. Does that sound sensible?
Yeah, no. If I cover the report, and then it naturally flows into the recommendations, which lead on to 4.2 and 4.3 anyway, where obviously Amy can pick up some of the detail. So Tim Harry, non-exec director and chair of the People Committee. Apologies in one way, you've got a slightly longer report than normal, and the reason for that is that we're covering 2 meetings. That was just the way it happened to sort of work out. So just a couple of key points. At the May meeting, we had a deep dive on recruitment, and we had assurance and heard about positive improvement across a range of measures through the wide range of interventions being implemented. What we did get assurance was that there will be continuous monitoring on the effectiveness of those interventions, and they will be adapted as required. More work in a couple of areas to do on the impact of vacancies on the quality of services and delivery, and that's coming to I think the next People Committee and then on to the board. And I think that, together with the zero-based budgeting, will really get us to a point of a much better understanding of what I would call the true vacancy requirement sort of level. So I think the story continues around that. The July meeting had a focus around EDI. The staff story, I personally found, and I think everybody else found, was particularly hard hitting, with some really concerning staff experiences of racial discrimination. We also received a number of annual reports and associated action plans. What I would say is, whilst these are obviously important and paint part of the picture, that they do provide important context, I think, for the board, because one of the recommendations from the board was that whilst we have a number of actions in place in a number of these sort of areas, we believe that we need to have a deeper conversation at the board level to talk about what is our ambition, what are the further actions and interventions that are required to help address what is obviously a very complex situation. So resulting from the meeting, there are 3 things, 4 asks of the board. One is there is the annual EDI report, and we are obliged to publish that on our website. So we're asking the board for approval of that. And then you've got items 4.2, 4.3, the 2 standards and action plan papers that Amy will talk about, which are here recommended by the People Committee, but with the caveat that further discussion, we believe it's important that we have further conversations and identify and agree what further interventions that we want to put in place to meet our ambitions. Hand over to Amy.
Thanks, Tim.
Thanks, Tim. Hi, Amy Beaton, Director of People. So as Tim said, Kevin, I will try and do all these 3 papers together as you've proposed, and as Tim said, they did go to the July People Committee for a deep dive, and we are seeking approval today to publish on our website and submit to NHS England. So the 3 papers, they're highlighting where there is good performance,
across. So I will refer to the Workforce Race Equality Standard as the RES and the Workforce Disability Equality Standard as the DES today. So there are areas we're performing well, and we're closing the gap in the experience of our white staff and BME staff, or our disabled and non-disabled and male and female. But there are also areas where we have seen worsening metrics, and we are really saddened to see some of the results and hear the story that we did, as Tim highlighted. I would say in terms of gender pay gap, we have steadily decreased that since reporting came in on gender pay gap across the 5 years, albeit it's quite steadily a reduction. There is also a challenge in terms of the DES, so you'll see highlighted in the report around data quality. We pull from a number of different data sources around DES, and unfortunately there are varying definitions. This is a national issue. They're trying to deal with this nationally, and you'll also see from our action plan as well, we're trying to improve this position. But if we're reliant on this data in order to set actions such as targets, it's important we get it right. And as the paper highlights, there's quite a stark difference between percentages of those who identify as having a disability dependent on those data sources. The paper does highlight national benchmarking, and I wouldn't want the board to think that we're doing that in terms of complacency, to say even though our metrics have gone down, we're still nationally benchmarking positive. That's not the purpose of putting it in the papers. The purpose of putting it in the papers really is to highlight the systemic issue that we are facing, the structural inequalities, and the challenges this will pose for us in shifting some of those metrics. So setting the expectation that some of these will take a long time for us to shift, but we are really committed to doing so, and we know this involves both having the right systems and processes, but also importantly the right culture and behaviours. So board will see the comprehensive action plans that are in the appendix of each of the 3 reports and how we intend to achieve this. And I just want to assure that this has been, all of those have been put together considering national best practice, research, case studies, but really importantly, co-production with our staff networks. So all of the staff networks that are mentioned in there, all of our colleagues, operations, corporate services through our people and workforce advisory group, and through our staff engagement cycle through the events we run. And engagement will continue throughout the implementation of these action plans. So the plans do show how we will measure our impact, both quantitative and qualitative, and to provide assurance further, these action plans are all reflected in our annual people work plan that sits under our strategy, which contains more granular detail than what you're seeing today that will be submitted to NHS England. And that is monitored now bi-monthly through our subcommittee of the board, the People Committee. So frequent monitoring of this plan will occur with executive and non-executive directors, as well as through the governance structures below the board committees. So what this means, if we're not seeing the impact we expect, we can discuss whether this needs longer to embed or a change of approach. And as has been highlighted both by Kevin and Tim, we're also committed as an executive and board to further discuss our role around this agenda and challenge ourselves as to whether we're doing all we can, knowing the importance of our role and around the cultural piece associated with this. So Chris Wright, one of our non-exec directors, highlighted earlier around the importance of culture and us really reporting around that culture, and that's the bit that we want to continue to have the discussion on to make sure that we're doing all we can in this space. And that has been agendaed for development sessions, private board, and we've got that to make sure that we've got a frequent discussion in this space. But we are already doing a lot of work in that, and what I would highlight is we do have our medical director as our exec sponsor. Well, all of our execs actually are an exec sponsor onto the staff networks, and things that we put in place more recently in terms of ensuring we've got real scrutiny on some of this. So Chris's point around making sure we're getting on the floor to really listen and engage. And I think from a gender pay gap point of view, we have had feedback that a recent appointment to the board of a part-time executive director has sent really positive messaging out into our organisation. I'll leave it there. Thank you.
Thanks, Amy. So there are, I think, there's a kind of process question, isn't there, for the board, which is to approve the action plans and the stuff that needs to be published around the 2 reports, and that, in a sense, that's the easy bit, not least because of the way in which you've described those action plans having been developed, Amy, with a degree of co-production and all the rest of it. So the first question I'm going to ask of board colleagues is whether or not they're content to approve for publication both reports and both action plans. If you can indicate whether or not you are, then that would be great. Thank you. And then the second recommendation, and the more important one in a sense, Amy, is around how the exec team and board satisfies itself around the cultural elements of this, the organisational cultural elements of this. And it goes back to the point, doesn't it, illustrated by Sally's story, right, an hour and a half ago, about how we bridge the gap between reporting on metrics and reporting on people's actual experience, and that plays into the staff story that you heard, Tim, at the People Committee. Now, you've said, Amy, that we've got this on the agenda for future board development sessions and private board. Can you just unpack a little bit what you're proposing that we should engage with in those fora, just so that we can get a sense this morning of whether or not we think as a board that we're going to be tackling the right things in those sessions?
Yes, I'm happy to.
Thanks.
So I suppose there'll be questioning for the board to ascertain whether we are really got the focus we need on this and whether we are interested in implementing positive action around some of this. So, for example, you'll see from the reports that our workforce representation in terms of protected characteristics isn't mirrored in every level of the organisation. So we have had some challenge from NHS England around our representation on board or in our senior leaders. So there'll be questions for us as a board. Do we want to set ourselves ambitions to ensure that we're representative of the workforce in terms of some of those protected characteristics? There'll be conversations around our visibility and role modelling and storytelling in that space, and how we would want to engage with our workforce around expectations and sharing of conversations, because some of the feedback we're receiving is it's more difficult to have these conversations in this space sometimes, and some of our staff are worried about having conversations in this space. So it's challenging and making comfortable our organisation to be curious and open. So target setting, positive action, our role, how do we want to be visible beyond myself being an SRO on some of this work. So that gives a flavour, Kevin. I can go into more detail if needed.
No, that's fine. I think we need to ask ourselves a really simple question, and I'll leave it to you, Amy, to think through how best we ask this question of ourselves as a board. I'm not suggesting we ask that question now, because it requires more time than I think we can give it this morning. But the question we need to ask ourselves arises from the staff story that the People Committee heard. And in your report, Tim, you say that staff no longer report anonymous concerns because they don't, effectively staff aren't reporting concerns because they don't have confidence in us as a trust to deal with them appropriately or at all. Now, that's a really, really challenging question that we have to ask ourselves, and we have to ask ourselves how we address that, and how we as a board restore that level of confidence that at least some of our people currently don't have. And I don't think the response to that is something that you capture in an action plan. That's something that is intensely kind of behavioural, and we need as a board collectively to face up to that criticism and make sure that we're clear about how we respond to it.
Thank you, Kevin. And I think that there's this is an area where triangulation of data is not always going to help in terms of we are hearing when we look at our HR metrics. So you'll see from we've had Freedom to Speak Up Guardian report, or our ER, our employee relations metrics. We're not always seeing bullying and harassment cases increase there. We're actually seeing them decrease. Yet through our national staff survey results, which is anonymous, we're seeing that increase. And so it's the triangulation piece wouldn't necessarily show that, but it's ensuring that we're listening and engaging, as you say, through that qualitative rather than.
It's the same. Forgive me, Amy. It's the same sort of gap as we saw around the patient story this morning, and that is we have data-driven metrics that tell us one thing, and then personal experience that tells us something that might be quite different. And I don't think it's just a matter of properly triangulating the data. I think that we need, if we've got one member of staff that is attending the People Committee and saying that I and my colleagues don't feel listened to, then no amount of triangulation kind of gets us out of that, as it were. That's somebody's real experience. And I think we need to think really carefully and really profoundly as a board about how we respond to that and how that affects what we do. Sarah, I can see you want to comment.
Yeah, thank you, Kevin. Sarah Connery, Chief Executive, it was on that because I think we sometimes tie ourselves in a knot around, does increased reporting mean we've got a problem, or does increased reporting mean that we're just becoming aware of a problem because people are feeling more confident to speak out? It's the same that we have with our Freedom to Speak Up report every year, where we see increasing numbers of people coming forward as almost a positive, because actually we're creating the right conditions to feel empowered to do something about a negative experience. So I think it ties back to work, as you said, Kevin, about our trust strategy and hearing people's experiences. So I was very disappointed to read the staff story, but also delighted that someone felt brave enough actually to come and talk through, because it was so powerful. But my comment was going to be, I think in some of the we spend a lot of time, don't we, talking about EDI in relation to staff and not necessarily to patients. But I think some of the threads in the action plan will actually, because it has such a cultural stance to it, will actually have positive improvements to our service users as well. But it's just a plea really that we keep thinking about what is right for Lincolnshire. There's a report that's just been released around service user experience in Boston for people from Eastern European countries, for example. So this is a sort of multifaceted issue that we faced with lots of intersectionality. So we've got a lot of work to do, and I really welcome more time in a board development session to really unpick some of it. So, but thank you, because there's a hell of a lot of work that's gone into getting these action plans where they are. So thank you.
Thanks, Sarah. And just echo that. Thank you very much, Amy, for the work that's gone into this, and thank you very much, Tim, and the People Committee for helping to hold an important mirror up to the organisation and hearing and reporting that staff story. And we will come back to that as a matter of urgency in board development. Do you want to move on? Are you happy to move on, Amy, to the gender pay gap report?
Yes, I can. Thank you, Kevin. This is also for approval in terms of publication. You'll see the gender pay gap report is attached as an appendix, and again is to be published and submitted. What it does highlight is we do have a gender pay gap, so males are paid 17% more than females as a mean average and 13% as a median, but both these averages have been decreasing over the last 5 years, albeit steadily. Our gender pay gap is driven by the fact we have an overrepresentation of females working in the lower pay bands, but underrepresentation of females in the upper pay bands when considering our 81%, 19% female to male workforce demographics. So this then tends to, this trend then reverses for males working in our organisation. We do benchmark around midpoint when it comes to comparing us to the 217 NHS trusts nationally, and we do benchmark positively within our ICS. But as I've said with the other two reports, the plan has been done with the engagement of our women's and allies and our men's and allies networks, and we've put together an action plan that we do think will support in further continuing to see that trend of reduction, but noting the systemic issue that we face in this area. Also, this will be a discussion at the board development sessions along with the RES and the DES on what can we do more in this space. And as I said earlier, the recent appointment to our own board of a part-time colleague has sent a huge messaging that we've picked up through our networks and our operational visits that has sent some real clear messaging. Thank you, Kevin.
Thanks very much, Amy. Any questions or comments for Amy or on the report? So the question is that the board approve the report and action plan for submission to the Government Equalities Office or to the website. Are colleagues happy to approve? Good, thank you very much, everyone. Let's move on then to the final item under the people heading. Girish, which is yours.
Good morning. Thank you, Chair. I'm Dr. Girish Kunigiri. I'm the Medical Director for LPFT. I take that the paper is read. I just want to give a brief background about the appraisal and revalidation for doctors, which is a little different from the other staff in the organization. Appraisal and revalidation is a very intense and robust process, which is set out by the General Medical Council for all the doctors. This is to assure that the doctors working in the organization have the right competencies and values to perform their roles. In this, appraisal is an annual process, and it's very intense and sometimes it can take up to 8 to 10 hours of preparation. And it involves collecting a series of evidence related to how the doctor is performing the good medical practice, adhering to the standards, and also participation in at least 50 hours of continuous CPD events. They are also expected to attend regular peer group meeting where they reflect on complex cases, and also during the appraisal, they are expected to collect and reflect on all the concerns, complaints, and severe incidents if they have. So the appraisal in itself, between the appraisal and appraisee, can be up to 2 to 4 hours of their time. Revalidation is a process aligned with the appraisal where the General Medical Council is satisfied that the doctor engages in the annual appraisal process and also gets a 360-degree appraisal, including the patients and carers' feedback, and it should be at least 25 of them. And then following this, the GMC issues the license for the doctor to practice, which is for up to 5 years. So the revalidation happens once every 5 years for the doctors. So all the doctors in our organization, as you can see in the report, are revalidated, and they have the license to practice, which was issued within the last 5 years. With regard to the appraisal, annual appraisal, as you can see, as of 31st of March, which is the cutoff date, which measures across the country, the compliance was about 80%. And by the end of this week, it is expected to be 96%. The 3 of the doctors who have not had their appraisal for personal reasons, they are engaging well with the process, and we are getting the dates confirmed and the appraisals confirmed. I do know that we need to improve the compliance by the doctors. So I am working with my Deputy Medical Director, who has appraisal as his portfolio, and the appraisal admin within our organization to develop a process in terms of improving the compliance, and the details will be submitted to the People's Committee in September. So I'm happy to take any questions, Chair. Thank you.
Thank you, Girish. Apologies, colleagues, having trouble unmuting myself there. Question from Chris.
Thank you, Kevin. Thank you, Girish. Chris Wright, Non-Executive Director. Sorry, I haven't previously described myself as such. Girish, I'm just linking this back to the patient story at the beginning. Part of the appraisal process requires feedback from patients. I wonder whether there's an opportunity for doctors to actually meet. You describe the peer process where they come together to discuss complex cases. Is there an opportunity for the doctors to sit in a group and listen directly to patients tell their story?
Thank you so much, Chris. That's an important suggestion. At the moment, it is not mandatory that the doctors, when they are doing the reflection, they sit with the patients. But in terms of their usual clinical day-to-day activities, there are series of multidisciplinary team meetings which do happen, where patients are part of that annual, what we call as care program approach, where the patients and the family members are the part of those MDT discussions, where the doctors along with other professionals do make a discussion and decisions in terms of care planning, where the patients are definitely involved in that. The second thing is I just emailed Donna as well in terms of how do we make this a postgraduate meeting on a regular basis. At the moment it is more like a one-off, but how do we make it as a regular basis so that the patients and family, after they have discussed about their issues, how do we use that forum to self-reflect as well? Thank you.
Thanks, Girish. Kevin, if I may, can I just come back? Thanks, Girish. That sounds good. And I hear what you described as the mandatory process, and I'm interested in what flexibility or what scope there might be to add to the process best practice. And if it was part of the formal appraisal system, where that patient feedback was received directly, I wonder whether it might have a different effect on performance. So my question is, have we got scope to broaden the appraisal process? Could we do something innovative? And if it was directly related to the appraisal, there might be a correlation with performance and different impact for patients.
Yeah, thank you, Chris. I will definitely take this back to my team and then see how we can do it creatively so that it is meaningful and more productive both to our staff and also to the patients. Thank you.
Thanks, Chris, and thank you for that response. Girish, it sounds really positive. Ian.
Yeah, thanks. Thanks for the report, Girish. It was helpful. My question was, excuse me, really just around locums and any use of locums. What sort of assurance you receive, I suppose, as a client, if you like, on that, just to make sure that that's as strong as it can be.
Yeah. Thank you, Ian. That's really helpful. So in terms of the locums, we have two types. One is the trust locums, who are actually employed by the organization for a fixed period of time. For those patients, we use the same appraisal process as we do for the substantive consultants. So they have the annual appraisal and I am the responsible officer for them, and I do the recommendation for 5-yearly revalidation for those. So the appraisal process is exactly the same. For the second type of locums is the agency locum, who are coming to our organization for a shorter period of time, and they are supplied by the agencies. So in such case, the agency is responsible to ensure that the doctors who are registered under them, they have their annual appraisal and they also have their 5-yearly revalidation. So most of them agencies, either they have their own responsible officer or they are linked with the responsible officer who will make sure that they have annual appraisals as well as the revalidation. And anytime we are appointing anyone in our organization as a part of our health check, we ensure that the people whom we are appointing, they have their annual appraisal and also look for their GMC registration and the 5-yearly revalidation, which is on the GMC website. Thank you.
Thank you.
Thanks, Ian. So the question for this morning then, Girish, is that the board accept the report and approve the statement of compliance.
Yes, please.
Yep, so colleagues happy to do that, please. Could you indicate? Yep, that's great. Thank you very much. Thank you, Girish. Thank you for that report.
Thank you.
we'll move on then, if we may, to item 5.1, which is highlight an exception report from the Sustainability Committee. Chris.
Thank you, Kevin. Chris Wright, Non-Executive Director and Chair of the Sustainability Committee. Take the report as read. Some key points. We received a deep dive into the role of the voluntary sector supporting mental health across the county, and given our new strategy, we were very interested in how we could build an ecosystem designed to both deflect people from the formal system, but also how we might think differently about who actually provides services going forward, and recognizing that there's a huge capability in our communities that we could tap into. And so there's a lot of really good work going on around that. And I think as the strategy unfolds, I'd like to think we will see a greater engagement, a greater capacity from the voluntary sector supporting our overall work. The other focus of the Sustainability Committee is very much on, forgive the pun, but on how we become a sustainable organisation. And so there's quite a lot of work going on at the moment around demand and capacity, and trying to understand the cost base of Lincolnshire Partnership Foundation Trust, so that we can ensure that our resources are being used appropriately. And we are receiving reports from different parts of the organisation at the moment around that, and we'll keep a very laser-like focus on our cost base. We received, importantly, progress reports on waiting times for both child and adolescent mental health services and also autistic assessments. In relation to our child and adolescent mental health services, there's some good progress being made. The trajectory is looking pretty positive, but still work to go. In relation to autistic assessments, last year there's been quite a lot of disruption in the system, and we are now taking formal responsibility for the management of a contract around external support in relation to that, and but we recognise performance isn't where it needs to be, and we will continue to press and keep a beady eye on that. Just to reiterate Sarah's comments in her report about the major capital programme and the opening of Castle and Ellis wards, just a really good delivery of a capital programme, and lots of people involved in that need to take huge credit, Mark in particular. And now the focus is very much on Boston, and ensuring that we can eradicate the dormitories at Pilgrim Hospital. And then finally, we received a report around the closure of Ashley House, where we recommended to the board that we would take that course of action. So that's it from me.
Thanks, Chris. It's really helpful report. Excuse me. And an impressive range of business that the Sustainability Committee has been covering. Really pleased to see the work that you've been doing around the voluntary sector capacity, which I think links in really strongly to the Trust's new strategy, and looks like it's a really helpful piece of work. Any questions or comments for Chris? I don't see any. Thank you very much, Chris. We'll move on then to the integrated performance report. Mark.
Hi, good morning everyone. So I'm Mark Platson, I'm the Director of Finance, Digital and Estates, and I'm here today to present to you the integrated performance report. So for those eagle-eyed, you may notice that the format of the report is slightly different this month and ever evolving. So this is on the back of a number of discussions that we've had through board meetings around how can we look to better triangulate our data and make more sense of what's going on across the organisation and bring performance and quality and people and finance to life and really start to understand what's happening. So the business intelligence team within the digital and data services function have been looking at this and working closely with colleagues. So we may start to see future revisions come through, and we'll work with board colleagues to kind of refine that. But I'm just going to pick up on a couple of the key highlights, because the report kind of does pick up on a number of key areas. The first one's around vacancies and how they continue to impact on our operations. Again, consistent with conversations from today, that there are some quite key areas of localized focus that we need to look at, such as the crisis enhanced treatment team in the south of the county and some other areas. But I know Chris is going to pick up on that as our Director of Operations in his update report that's probably going to follow this report moving forward. So happy to pick up any questions on that with Chris. Something I did just want to pick up as well, and it kind of links into Sally's story early on, really, is because of the level of vacancies and what's happening across the organisation, we do continue to be heavily reliant on bank and agency and that temporary staffing support, which can start to have an impact on the quality of our services. And I know Sally mentioned about that limited, consistent clinician interaction and I think we need to be very mindful that as we continue to use bank and agency and become reliant on that. So from a spend viewpoint, we are actually over plan at the minute, and that's something we need to address as an organisation. But actually from a quality of service delivery perspective, that's something we really need to understand, to see how can we get that regular contact with our patients using substantive staff as much as possible. So again, something we know that we're working on. So in terms of trust-wide metrics, there are some in there where we are underperforming, and that there are updates around how we're going to bring that back on track. But happy to, alongside executive colleagues, take any questions on the report or the content within it, and we'll note Chris's update that will follow this one. Thanks, Chair.
Thanks, Mark. Of course, Chris's update should have come before this one, but the chair ticked off one too many items on his agenda, so it's all right. I'll dock myself a day's pay. Any questions for Mark or other exec colleagues on the performance report? I don't see any. Which is a reflection of the fact that it's a really comprehensive report with a good commentary, Mark, but also most of the important issues in it are issues that are well known to us and that we've discussed either today or substantively at recent board meetings. So I'm not really surprised that colleagues don't feel the need to rehearse them again today. Chris, though, has got a comment. Sorry.
So just a comment, and Chris Wright, non-executive director, just to take advantage of the opportunity to make the connection between our current challenge around recruitment and the points we were raising earlier around the role that the voluntary sector more broadly might be able to play in the delivery of mental health services across Lincolnshire. And I think there's a cultural challenge for us, which is that we have to stop thinking that we might be able to do everything and that others might be able to do it for us. And not to suggest that recruitment isn't a challenge for lots of organisations, but people often want to work for different types of organisations. And it might be that we need to think differently about commissioning, about whether it's right and proper for LPFT to be the provider of secondary care in its entirety, or whether we might look to others to provide that support. Now, the reality is that the capability might not be quite there yet. So what role can we play as the leaders in the field to build that capacity at a local level to help fix some of our own internal challenges around delivery? So it's just it's trying to make the connection between where a lot of our challenges are to do with the fact we haven't got enough staff. Frankly, it can be reduced to that, and so we need to think differently about how we go about that and how we link the performance that we're reporting on to the strategy. And part of our role in the strategy is building capacity elsewhere and out with LPFT. Thank you.
Thanks, Chris. That's a really important point, and it links back to the trust strategy that we approved earlier this morning, that not in quite so many words, but is predicated on exactly those assumptions, that one of our roles as a trust is to build capacity and capability across the system, whether that capacity and capability is directly delivered by LPFT or in partnership with others. So, you know, I think that's absolutely right. So that's a really helpful comment. Thank you, Chris. Sarah.
Yeah, thank you, Kevin. It's more a comment and a question. First of all, it was around the safe staffing, and I really welcome the format where we focus the mind on risks and issues and then action and update. But there was just a comment around patient safety risks as a result of safe staffing, and it sort of says unable to measure impact on quality of care. And I think it links back to a sort of bit of a thread to our conversations today, where I think we don't currently measure it, but I don't think that's a reason why we shouldn't at least attempt to measure what the impact is, or there's not much point, I suppose, in doing the report if we're not able to measure that somehow. So that's just a question for us on the back of the strategy discussion. And then a quick one for Mark, because we did have an issue previously in the last financial year around our better payment practice code, and it was, is that something that we look at in the sustainability committee, or, you know, are we trending quite well on that issue at the minute? So thank you.
Yeah, brilliant. Thanks, Sarah. I think that the point around those quality links is really valid, and I think this is something we're pushing the team to develop even further. So the report format slightly different this month. We're going to look at that triangulation greater moving forward. In terms of the better payments practice, we're not really looking at it at the minute, because I think I need to give. We've just recently implemented a no purchase order, no pay policy as a Lincolnshire system. So we haven't done it in isolation as an organisation. And I think as a result of that, the first month I have seen a slight dip, if not a kind of a drop, or just about maintain where we're at, because of the number of purchase orders that we're having to raise through for that first time to get the setup ready. So I'm going to let that bed down, and then we'll look at the performance through sustainability as a bit of a deep dive, so that I can evidence the benefit of doing that, because actually it gives us greater control, greater understanding of what we're purchasing and how we're purchasing it and who we're purchasing it from. So I think there's a bit of a bigger picture to it now. We've gone to that no PO, no purchase order, no pay, but we will update Sustainability Committee and Audit Committee from an internal control perspective moving forward.
Thank you.
Thanks, Sarah. Di.
Thanks, Kevin. Di Bailey, Non-Exec Director. Mark, just in terms of the information in the report, it looks to me like there's an upward trend in terms of the patient safety and experience serious to moderate incidents, albeit maybe small numbers. But given the conversations that we've been having about staffing across different services, are we looking early enough at where we've got those hotspots in terms of some of these incidents being reported, and where we've got those staffing issues, in order to be able to be proactive in a similar way, I guess, to the work that's going on in terms of our inpatient services?
Yeah, it's a really good question. Thanks, Diane. I don't know if Marhouse will want to come in, but I think this is part of how we're moving forward with our patient incident reporting. and certainly the new processes that are coming online will help us to be more proactive in that and start to understand certainly early. But I have seen Mark's face pop up, so I will hand over to him to give a bit more of an informed answer on that one.
Thanks, Mark. Mark Holsall, Deputy Director of Nursing and Quality, here on behalf of Sharon Harvey, Director of Nursing and Quality. Thanks, Di. Really good question. These are areas that are considered and they are actively monitored and assurance provided through Quality Committee. What I can say today is that we've not got particular hotspots. There's no relationships between the incidents, but I think what it does link back to is Sarah's comment previously about the conflict of increased reporting, evidencing a good learning and reporting culture against raising concerns. And I think what we really need to do is, as has been suggested by Mark, it's about having that greater depth of knowledge and understanding within the incidents and what these incidents actually mean to the individual concerned. I think moving on to the second part of the meeting as well, I'll be able to make a link and more of a reference between the data that's in this performance report and the plans around the Trust's implementation of recommendations from the rapid data review that you mentioned previously.
All right, thanks, Kevin.
Thank you, Di. Thank you very much, Mark and colleagues, for the presentation of the IPR. Shall we move on to the item that I should have taken before the IPR? And Chris, I think it's fair to say, isn't it, this is your first stab at an operations report, so we should be slightly gentle with you in terms of format and content, because I'm sure this will evolve over time. But I really welcome it. Really welcome, the fact that we've got, your judgment on hotspots and other things around operational delivery. So I'll let you speak to the report as you wish.
Yeah, thank you, Kevin, and absolutely welcome any suggestions in the meeting or outside the meeting about what would be helpful in terms of content going forward. But this has come about. Previously, I provided quite an update in the integrated performance report, but as we've moved the format of that, we took the decision to write something distinctly separate, and equally because we're now looking at data that's 2 months behind in the IPR to make sure we've got the data accuracy and the opportunity of triangulation. Through this report, it's an opportunity to really present the here and now operational issues as I've identified them. So I won't go through it all in detail. It's just to flag a couple of bits. One, as we've kind of mentioned throughout the meeting and previously, is that workforce remains one of the biggest challenges to operational delivery, but that's in specific areas. And what I would say is, at the moment, because of the level of vacancies we've got, it's an employees market. People are able to move around to new opportunities quite freely. The consequence of that is that we see hotspots moving around the organisation. So you'll see for a while we've had issues in recruitment for the early intervention in psychosis team. We had Boston CMHT that were really low in numbers, and now we've recruited to full establishment, and those are improving or have improved. We've got persistent issues around our inpatient and urgent care division, which again well rehearsed in the board. That's starting to improve, some green shoots of improvement across a number of metrics, including vacancies, but also sickness and turnover. But it still remains a challenge position, and we need to keep continued focus on that particular area. And that links into the PQ conversations. We'll bring a position statement in September on that, and the plans to reopen in November. But at this point, we remain on track. And similarly, persistent issues in our SET South team, our crisis team for children and young people in the South, where despite numerous attempts to try to recruit, we're still struggling to get the numbers up to full establishment. Because of that, we've got to rely on some banking agencies, as you would expect, to make sure we've got safe and effective services being delivered, but that has a consequence, obviously, on our financial position and the commitment around reducing agency costs this year. So a bit of a mixed bag on those issues. In terms of positive developments, though, just to say, again, linking back to conversations previously and the work we're doing around VCSE and other partners to be able to extend our care network and offer, and those people who might be in a better place to recruit and support past the pathway. There's a range of transformation programs underway at the moment that are really stepping into that space, some more advanced than others, but really helping to develop those relationships with other partners in the system to be able to provide a much more holistic care pathway for people and the system as a whole. Importantly, as I mentioned in the report there, is we've just recruited to a new Associate Director of Planning, Partnerships and Development. It's a new role for the organisation, but that's going to take a key role in developing those partners, both in terms of people who are existing, but also helping that market warming, market stimulation to get new partners into the patch. So more to come on that space. And just a couple of bits just to flag is Ashley House, as we mentioned, decision was taken last month to permanently close Ashley House in favour of a new and more modern way of working through a community rehabilitation service at a county-wide footprint. We're now progressing with that. Just to let you know, that work is now underway to make sure we mobilise that service in a timely way. We're looking kind of end of quarter 3, quarter 4 time for that service to be up and running. And we attended Health Scrutiny Committee early this month and received some positive feedback on the way that the approach we taken to making that change. Also, just to say, because I know the board are interested in this, is that the female PQ remains an issue for us in that it's an inequitable service. We provide, or will be providing again, male PQ in county, but we don't have provision for females. We're looking at a number of options to be able to provide that service in county, and we're looking to bring something through Sustainability Committee in October, and then with onward assurances and options through to the board after that. So happy to take any questions on any of that, and again, content and format going forward.
Thank you very much, Chris. I think I've got Di first.
Thanks, Chris, and thank you for the report. I found the report really helpful, particularly because of sitting on the system level performance and delivery committee and seeing the transformation programmes now here at our board, which also report into that committee. So that I found really useful. And I think one of the things that we could do going forward is where we are reporting on that performance of those transformation programmes is marry up what the system are giving us in terms of dashboard and metrics with what we get here, so that we're having that sort of consistent conversation. The other thing I just wanted to add was in relation to the conversation about culture, and what was really interesting for me was on a visit last week in one of the community mental health teams and one of the integrated place-based teams, where we have some challenges with recruitment of staff, was the real way in which the team leaders of both of those teams were working in an innovative and collaborative way to really think outside the box of situations where staffing was tight, and I just think it's those sorts of situations and that sort of leadership that we really want to learn from and cascade. So I think if there's any way that we can feed in a bit more, perhaps proactively, from those NED-ED visits into the information that's in the report, I think that would be really helpful going forward, because I think it'll tap into that cultural piece that we've been talking about so much in this meeting. Thanks, Di. I think that's a really excellent suggestion. And I can see Chris is taking a note. So watch this space. I think we can see something positive on that. Tim.
Thanks, Kevin. I'm not sure I dare ask this question really, because it's around process. And we're talking about culture a lot at the moment, and culture always trumps process. And maybe not an answer now, but I'm curious about, and it was triggered by Chris in your report around transformation programs and so on. It was great to see that all together. I'm also thinking about strategic review and implementation. I just want to ask a question about where we are with how we apply programmatic approaches, programs, projects, portfolios to make sure things are linked appropriately to strategic benefits and so on. So as I say, it's really a question maybe for another time, but perhaps if you can lodge it.
I'm happy to come back on that, Tim. That for a while now we've been talking about different functions, I suppose, in terms of transformation resource. So we've got some that sits within our adult community division, but benefits beyond that into the wider system, and certainly working with VCSE and other partners and across supporting the ICB. We've also got our own business development team, and we know that some of the work around that is changing in the number of tenders that used to come through. You know, it's far less, far fewer than it used to be. And so we are, through that new role that we've got in the organisation, using that as an opportunity to review and reset the functions around transformation resource, but also around what we've traditionally known as a PMO, and just to try to get some views around what would work for LPFT in kind of 23-24. So more to come on that, but absolutely acknowledge that we've got lots of different programmes, both in and external to the organisation, that we need to capture and manage in a systematic way, and that role is going to take that piece of work forward.
Thanks, Chris.
Thanks, Tim. Sarah.
Yeah, thank you, and thanks for the report, Chris. It's really helpful, and to give you that space to sort of, you know, share what's keeping you up at night. And I just wanted to build on Di's point really about there's a lot of focus there around fragility of services as a result of staffing, which of course is really important. But I think there's part of the equation that we're missing, which is activity and demand. Which can also lead a service to be fragile, and it could be fully established but still fragile because of increasing demand. And I think we did a lot of that focus work through COVID, and I think maybe we've lost that somewhere along the way. Not on a monthly basis, but I think it'd be really good if the board could have a common narrative on where we are around fragility of services as a result of staffing and increased demand, or maybe one or just the other of those, if that makes sense. So but it's really great report, thank you.
Thanks, Sarah. Echo that point, both that it's a great report and helpful, and I think, you know, is potentially a really important tool in bridging that gap between spreadsheet and experience, as it were. You know, recognising the fact that you can't reduce insight into the organisation down to a spreadsheet, but also, you know, triangulating it with demand, I think, would just round it out really nicely. But I know that's work in hand, but it needs to be, you know, kind of it needs to have life to it, and it needs to be a, you know, kind of evolving picture. Ian.
Excuse me, thanks. Ian Orrell, non-exec director. Yeah, my first point has largely been picked up. I think the point that's been made about linking the report to the sort of cultural aspects, I think, is really, really valuable. So I think it's a really good report. The bit I wanted to just pick up on the cultural bit was, given that, Chris, you're in a fairly unique position here, I just wonder, we talk about the staff vacancies and you know, the pressure point in inpatient. If you could give your sense on the patient experience as a result of some of that pressure.
Yeah, so varied, I suppose, would be my first word, in that most often we cover vacancies through bank and agency, or let me start that again. There are different impacts to vacancies. So some services are new and growing services. So we've just mobilised the community rehab service, for example. Now there isn't a service at the minute, and there is a number of vacancies that will suddenly appear in a workforce dashboard because we've moved to that community model. That's not causing any problems at the moment. In fact, over the next few months, 6 or 9 months, we'll just recruit up to that, and we're just increasing the quality of service and range of services that we've got available. So that's a positive vacancy in some ways because we're making more service available to more people. Obviously, there's other impacts in other areas. So the inpatient division is another example where we come to pressure, we really struggle, but we try to supplement that wherever possible with bank and agency. So there's a continuity care element and things that come into play. But on the whole, as you see from the integrated performance report, we do fill shifts safely and usually to optimum levels, but that is reliant on a temporary workforce. So it is different in different areas. What we've committed to do through some of the other committees is to do an impact of vacancies report, and that's proving to be inherently complicated, but we've looked at each service and where a team is over the kind of 12% target vacancy position, I'm asking the operational service to add some narrative about the impact of that on a number of different metrics. So that's just work in progress. I'm hoping to have something ready for committees in September that will start to quantify that by team, because it is different by team. So it's a bit of a roundabout answer to your question, but there is further work to do that at team level because not all vacancies are equal.
Thank you.
And I guess, Chris, that goes back to Sally's story this morning, doesn't it? So, you know, where we're covering, in terms of the patient experience, where we're covering vacancies with bank and agency staff, it increases the risk of that lack of consistency and continuity in care. So, the impact isn't one that's driven by vacant posts. It's driven by the way in which we inevitably fill those vacant posts, and that's not a criticism of the approach that we take. It's inevitable, but it does increase that risk, doesn't it? Okay, well, thank you, Chris, and as others have said, it's an excellent report, and one to be built on and to evolve. But thank you very much. Thank you very much for it. Let's move on then to, I need to make sure that I'm on the right place on my agenda this time and I don't skip too far ahead. Item 6.1, which is a report from the Audit Committee. Ian.
Yeah, thanks, Kevin. Ian, our non-exec director. Yeah, you'll be glad to know I think I can be pretty brief on this. I expect that everyone has read the report. I haven't got too much to add. In terms of a couple of items, though, that I should perhaps mention, we did look at the annual Freedom to Speak Up report. We went through that item and approved it. So I think in terms of process, we're asking the board to recommend its approval on that. And similarly, we also undertook an annual review of the trust standard financial instructions and scheme of delegation, where there were a few changes made to strengthen controls that, again, the committee approved, and we're asking that board also approve. One final point to add is we didn't look at the BAF on this particular round, but intend to at our next meeting, and that fits quite nicely with the conversation we had earlier around the trust strategy. So when we were talking earlier about needing to have the appropriate infrastructure in place to follow through on the strategy, then we should see what that looks like in the audit committee, and hopefully we'll be able to add to the process thereafter. But that's all from me. Thank you.
Thank you very much, Ian. So there are two. There's an amendment to standing financial instructions and amendments to the scheme of delegation, which we need specifically to approve. Is that right? Or yeah,
that's right. Yep.
Yeah. Okay. Thank you. So first of all, any questions or comments on Ian's report? Yeah, thank you, Karen, and the Freedom to Speak Up annual report as well. So there are 3 documents specifically for the board to approve. So there are no questions for Ian. I'm going to do this en bloc, as it were. It's starting to sound like the TUC conference, and I'd ask if board colleagues are happy to approve all 3 of the documents that we're asked to approve this morning. Great stuff. Thank you very much, and thank you very much, Karen, for keeping me on the straight and narrow. Thanks, Ian. If we move on then to item 6.2. So this is a proposal from me to appoint a new deputy chair and senior independent non-executive director on the departure of Sharon Robson. I'm proposing that the board approve, well, I'm proposing two things. That the board approve the appointment of Di Bailey as the senior independent non-executive director. That will be effective from August 2023. The decision to as to the appointment of a deputy director is a decision for the Council of Governors, but the board needs to recommend that appointment to the Council of Governors. So there are two things I'm asking the board to do this morning. The first is to approve the appointment of Di as SINED, and the second is to support my recommendation to the Council of Governors that she should be appointed as deputy chair. I'd be grateful. I'm happy to take any questions on those recommendations, but also would welcome colleagues' support for those. So if colleagues are content to support them, please can you indicate? That's fabulous. Thank you very much. Forthcoming board programme. Karen, anything you want to add to the paper?
No, thank you, Kevin. Just as in the report, just to note the cancellation in August of the board development session, which will be rearranged.
Thank you very much. I've not been notified of any other business. Does anybody have any? Don't see anyone. So thank you very much for everyone's contributions this morning. We heard a really powerful story from a carer, and I think although it was difficult to hear, it made some important points and some powerful points about where, as a trust, we don't always do as well as we would like to. I think the fact that throughout this morning's meeting, we've taken almost all of the discussions we've had back to the points that Sally raised this morning, I think is a testament to the fact that to two things. First of all, the importance of those stories, and secondly, of the fact that we do want to listen and improve as an organisation, and the trust strategy, again, which we've referred to, gives us an anchor point for that improvement, and the imperative is on us as directors to make sure that we turn the delivery of that strategy into more than just an Excel spreadsheet with actions on, and that we properly bring it to life. But I know from the conversations that we've had this morning that we're all committed to that. So thank you very much. Now we reconvene as in private for those matters, to discuss those matters that we can't do in public. My suggestion is that we take a short break before we do that. So I'm going to suggest, it's now 11:30. I'm going to suggest we reconvene at 11:45, do a bit of business on the agenda, then break and have some lunch, and then reconvene to finish the private agenda if people are happy with that. So if people are content with that approach, we'll end this public part of the board's meeting now and reconvene at 11:45. Thanks very much.
Thank you.